My name is Peter Rossos. It's a great privilege being here, kicking off this next panel, which is called Connecting Ontario, Getting It Right and Getting There. Just before we start, I'd really like to thank Michael and Lynn and the Infoway team for hosting this, for having us here, and congratulations on taking this to this level. You know, the whole idea around partnerships and bringing in so many stakeholders. I remember the much more modest days around poker tables and the old standards committee. So we've really gone a long way. And I think part of that is not just the better venue. It's the fact that we've demonstrated, significant improvements in outcomes in digital health. The very personal stories that we heard from our panelists and from everyone here, showing how we are improving care and creating better ways of engaging patients and providers and bringing them together, and more importantly, reaching out to society as a whole so that we have a healthier and more productive society. So part of what I'd like to do next is just to introduce you to our very distinguished panel here, and then I'll let them take the reins. And then, despite the fact that we've been truncated a little bit in terms of the session here, we'll make sure that we leave enough time for you folks to engage with us, because it's all around connectivity and sharing some ideas. So I'd like to, now many of you in the room may know Ms. Cynthia Morton. She's the CEO of Ehealth Ontario. I won't go through their whole bios. You can take a look on the Infoway site. You can also Google them and see what they've been up to in various aspects of their lives, which may be interesting. But needless to say, Cindy's been a major leader in the public sector, and I'm not exactly sure what motivated her to do this, but she took on easily one of the toughest jobs in the province, if not the country, in assuming this leadership role at Ehealth Ontario, where her major deliverable is an electronic health record to the citizens of Ontario. Next is Dr. David Daien. David is the division head primary care at Trillium Health Partners, which is a very large academically affiliated organization just a little to the west of us. And David and I got to be good friends and good colleagues as co-leads of the initial sort of phases of the Connecting GTA strategy. So that was an excellent bonding experience, David, and I thank you for taking time to be here. And similarly, Dr. Asim Masood, he's one of these emergency docs that likes solving problems, has a business degree. He's Chief Medical Officer for Canada Health Infoway, and he too was part of our interprofessional clinical working group on the Connecting GTA program. And then to bring a nice sort of ray of sanity, we have Ms. Sarah Hutchison, who's the CEO of OntarioMD. And so she hasn't been a direct sort of refugee or leader, or whichever way you look at it, of the Connecting GTA sort of program, but very much part of the Connecting Ontario strategy in terms of her leadership through many levels, social policy, privacy, et cetera, that have sort of shaped her into her leadership role with OntarioMD, which is primarily responsible for the EMR strategy among primary care and community-based physicians, along with many other aspects of information exchange in the province of Ontario. So those are the intros. I hope they're helpful. I think many of you may know, our panelists from other capacity. I thought just to sort of set the stage, we turn to leaders in other jurisdictions, and I looked for quotes that sort of reflected, I think, the way that some of us felt along this path in Connecting Ontario. So Winston Churchill, the pessimist sees difficulty in every opportunity. The optimist sees opportunity in every difficulty. And I think that was probably Cindy's major incentive for taking on the Ehealth Ontario position.
It was that one.
Margaret Thatcher,
Yeah.
You may have to fight a battle more than once to win it. I think that goes across. And then, of course, let's go back in history to Sun Tzu, and that is, if you know the enemy and know yourself, you should not fear the results of 100 battles. And I think we've probably hit 100 battles so far, and we're still going strong. So next, I just want to show you a little video, and then we'll get into some of the panelist presentations. That'll start with Cindy, then David, then Asim, and then Sarah, and then Cindy will bring this all to a great sort of conclusion from the panelist perspective, and then we'll open it up to you folks.
Ehealth Ontario is the electronic digital network that connects healthcare providers to your medical information. Using electronic health records and new digital systems, Ehealth Ontario enhances patient care so that health practitioners can access your medical records instantly, anywhere, anytime, and when it matters most. Today, Ehealth Ontario is enabling access to electronic health records of Ontarians from Kingston to Canada and from Toronto to Thunder Bay. Comprehensive patient medical records are accessible to tens of thousands of healthcare providers across the province.
Digital health in Ontario gives healthcare practitioners access to the information that they need when they need it in real time to take better care of patients.
You know, sometimes patients come to the office, they've been to the hospital, and they're very anxious about what's happened there. I can get that information, explain it to the patient, and allay all their anxieties and fears right there.
Makes it nice and easy when I come in, my file's right at hand. They don't have to shuffle papers or go looking for things.
I just finished cancer treatment. When you have serious ailments and medical problems, you would like to have the information and the outcome immediately.
Because I've had cancer so many times and chemotherapy so many times, I don't remember everything as well as I should. The fact that my family doctor can track my medical history and have a complete picture, to me, is the most important thing.
So when I log in, I get a one-stop shop of medical records in terms of consultation records, patient notes, but also labs, whether from hospitals or from external sources, pathology, radiology, and diagnostic imaging, and really anything that is put into text into the medical record of a patient.
At Ehealth Ontario, we're improving patient outcomes through electronic data delivery. We're using technology to improve the quality of your healthcare and how fast you receive it. We're making the system more efficient by connecting your electronic health records with the healthcare providers you rely on most. Ehealth Ontario is about you. It's about improving your healthcare experience. It's about finding savings and value for the Ontario taxpayers. It's about progress and the future.
So Cindy, thank you. Congratulate the team on the beautiful musical theme as well. And why don't we hand over to you? Thank you.
I have a really great video that has Dr. Peter Rossos and Dr. David Daien in it, but they told me I couldn't use them today. So, and actually one of the reasons why we picked the video that we did is because we really did want to reflect the patient's voice in our description of the work that we do. We provide tools to clinicians, but ultimately it is for the benefit of the patients. And so for the patient advocates and the patient voices in the room, I just really did want you to know that we understand that even though our job is to build the technology, it is solely for the purpose of enabling better care for patients. And so we very humbly accept that responsibility. And we know the work ahead of us is solely and purposefully driven by transforming healthcare for patients in Ontario. I have written remarks that my staff provided me, but over the course of the morning's conversations in this room, of course, they've all transformed for me what it is I'd like to say and to share with you this morning. So I also have to watch that clock there as well. I want to acknowledge that Ehealth Ontario is an agency whose journey has been a bumpy one, but it has been one, I think, ultimately of great success. And I'm very excited about where Ehealth Ontario is today and what opportunities are available to us in the next number of years to take what we have built that the video describes to you, so I won't go into much further detail about what we are doing at Ehealth Ontario, I think the real story for the province of Ontario, the patients and the clinicians and the partners to eHealth in Ontario, is taking advantage of the system that exists today in Ontario and using it more pervasively in more situations for the benefit of more patients across the province and in more diverse healthcare settings. I want to talk about partnerships and the partnerships of eHealth Ontario, and I think in this room we need to acknowledge that successes and failures of eHealth Ontario or any other part of the healthcare system is a bit of a reflection of the success of partnerships. eHealth Ontario is only one agency of many who are responsible for the design and delivery and rollout of digital healthcare across Ontario. And what progress we have made or what impediments we still face that we must overcome are shared amongst all of us. And one of the roles of eHealth Ontario is to figure out a better way to overcome impediments with you, because we have shared goals and shared purpose. And as an agency, we don't work alone, we don't struggle alone, and we don't succeed alone. And the partners who actually are sitting on this stage today are some of the most important ones that I've had the real privilege of working with at eHealth Ontario over the last 2.5 years since I joined the agency as its CEO. And to some extent, David and Peter have been what I would call my clinical spiritual guides. They have both really convinced me of the power and the opportunities presented to transform healthcare through the use of digital assets. And they really pushed and challenged eHealth Ontario and me personally to deliver better, faster, more relevant, easily used technology for the benefit of clinicians, knowing that unless we get to that place where the workflow of a clinician is not unduly disrupted by the digital tools that we can provide them, they will be of very little benefit in that clinical context. And so the people on this stage are pushing for the benefits of both clinicians and patients. And they really educated me around what is really important about what eHealth Ontario is doing and must do, and in fact must do better. We'll talk a bit about that later when we talk about the future. And our ray of sanity at the end there, Sarah, that's all I'm going to call you from now on, ray of sanity. But OMD has been a very important partner to eHealth Ontario because when we talk about building the electronic health record in Ontario, and even the video as it describes it, we're not just talking about an acute-centric kind of record of a patient. We're talking about making available patients' data in any clinical healthcare setting they may find themselves anywhere in this province. And so while the work of eHealth Ontario in particular has started and focused in the acute setting, because that's where the most complex patients find themselves and the costs to the system are the greatest, and so government went there first in terms of its investment in digital health. There has been a shift through the Patients First agenda of the minister, recognizing the value of keeping people closer to their communities, providing better health care closer to home, faster health care, more accessible health care. And so if we are going to assist in achieving that kind of agenda for patients first, closer to home, then the digital health strategy must follow that patient through their entire journey. So while our work began in the acute setting, it is now following the patient through their journey back to community and from community. And so the work between eHealth Ontario, OntarioMD is very important. I also really need to give a shout out to Canada Health Infoway. They've been a leader and a visionary across Canada for the value and role of digital health, pushing and persevering across very complicated pan-Canadian conversations. I'm a former deputy minister of a number of different portfolios. I know how difficult it is to bring governments and healthcare systems together across Canada and have a conversation where people agree to common goals and purposes. That is a huge challenge. Within one healthcare system, within one province, let alone pan-Canadian, an overwhelming challenge. And I really do want to acknowledge and thank them for that leadership. And I can't help but particularly acknowledge Mr. Graham Scott, the chair of Canada Health Infoway, who has become a real ally and colleague to me personally. The Minister of Health sought the advice of Graham Scott to give an assessment to the Minister of Ehealth Ontario's progress over the last number of years to date. And we worked very closely with Graham over the last year or so on that work. And part of the value that I will speak about later, and part of some of the future directions Ehealth Ontario intends to go, has been greatly informed and assisted by Graham in his work. So Graham, I want to thank you as well. I don't know how much time you want me to take, Peter. You just get the hook out and pull me when.
We'll bring it back to.
All right,
Put a nice close.
just cough when you need me off the stage. So just for those of you who are not from Ontario, Ontario is a very complex jurisdiction. You may all describe your jurisdictions as complex when you talk about healthcare, but in Ontario, we're trying to build an electronic health record that is available and of value and relevant to 14 million residents and available to 300,000 healthcare professionals. It will, when both completely built and fully accessible to all clinicians in all settings, be probably one of the largest publicly built and available electronic health record systems in North America. So we are not daunted by that challenge, but we need to understand the scope of that challenge. The other critical factor for Ontario, which may also once again be different from some jurisdictions in Canada, is that Ontario chose a slightly different path. Ontario chose not to rip and replace old systems and introduce a monolithic system that had some coherency and capacity to speak to each other with ease across healthcare settings in a digital way. Ontario chose to federate that which already existed in the system. There had been a lot of investments in IT in a very smart, sophisticated healthcare system, but those investments were not coherent. They were often siloed. They were often incompatible with each other. So some of the journey of Ontario has been informed by the challenges of integrating and federating very diverse, very different systems across the healthcare system, extracting data out of those systems, sharing data across those systems with some coherent sense of security, privacy, and authentication of users and patients. So that has been no small feat. And we are there today. We have an EHR that is alive and used by some of the very clinicians on this panel, and they'll speak to their experiences. It has been designed by those same clinicians. They have been at the table from the very beginning, pushing and pulling the technologists to be informed and make priority choices based on clinical need and patient need. So the journey of Ontario has been a challenging one. It's been a complex one. But we are today at a place where the electronic health record exists and is proving its value daily in clinical settings. So I'll leave it there, and I'll let others speak, and we'll come back and talk more about the future in a minute.
So Cindy, thank you very much. Perhaps David, would you like to?
Love to. Thanks very much. And thanks to Infoway for inviting me to participate in the panel. I think my role here is to talk about some lessons learned from being in the clinical leadership space on this connecting project as it relates to the Greater Toronto piece. For those of you in Ontario, you would know this, but for the rest of the country, you should also know that there are 3 other connecting hubs, and Connecting Ontario Greater Toronto has learned lots and continues to learn lots from the other hubs connecting Southwest Ontario and the emerging Connecting Northeast Ontario, so I wanted to put that out there. So I've been in the role of co-leading the clinical working group for the Connecting Ontario Greater Toronto portion for, I think, 6 years, and been involved with the project even longer. And the first thing that I would say in terms of the lesson learned is sort of endorsing something that Cindy just said, which was about clinical engagement needing to be across the life cycle. Just as we've heard from patients that patient engagement needs to be present across the life cycle, so too the clinical engagement. And when you do that, at least how we did it, we started with some high-profile champions. It was a small core group. It was partly handpicked and partly provided by the jurisdictions that we were going to be serving. And I think that model is actually a good model, because if you only handpick, you only hear the voices that you want to hear. And if you leave the entire composition of your working group up to somebody else making the choice, you may not actually get the leadership that you wanted. And the one thing that I think that we have done well is we did manage to involve clinicians in all aspects of project from conception to delivery. So project initiation, requirements gathering, procurement, and I can tell you Ontario has some pretty challenging procurement rules. Design, build, testing, adoption, evaluation, every single stage we involve clinicians. And I think the learning in that story is that clinicians who are right for one stage might not be right for the other stages. So think about that, for those of you that are building projects and running projects, that you may need to evolve who your champions are depending on the stage that you're at. Some people have tolerance for strategy and thinking forward, and some people just need it, will only participate when there's something that they can react to. And therefore, the timing of moving from your small group to the large group is always a big deal. And I think that was a difficult piece for our working group as well. Those of you that might have heard me speak on other occasions might have heard me say it, but I'll say it again. There's really only two ways to engage clinicians, too early and too late. And those people that have to do physician engagement in particular have suffered the damages that incur when you do it either too early or too late. So the truth is that most clinicians need something tangible to work with. And that's why my comments before, you've got to start small with people who actually have an appetite, who actually will attend a meeting, who actually can see the value in having a conversation. And then when you have something more for people to react to, you can go to a broader engagement plan. So we did that well. What we didn't do well, I think, actually, is we didn't plan for succession. Those of you that are in large organizations, you undertake that exercise on a regular basis. Clinicians who do this role often on the side of their desk or as only part of their role don't really think very much about succession. And I think it's something to put in clinicians' ears. Think about the fact that you won't necessarily be in this leadership role for the next 10 years, the way that you'll be in your office for the next 30 years. And think through how to mentor the next set of leaders. And so, bad on me. This is an electronic health record activity. And not everybody who works in healthcare understands what that means in terms of impact on the ground. So I think it's really important that you get a common understanding of what's the role of the tool you're deploying. So an electronic health record for a lot of folks will be a secondary system. And that's an important thing to realize. It's not, for most people, it's not their point of service system. It's not their EMR that they're documenting in, or it's not their home care application that their home care organization provides them. It's a secondary source of information for a lot of folks. And that's a really important thing for funders, vendors, everybody else that's counting benefits to get their head around. So when you have something that's a secondary system, it means that there could be a lot of infrequent users, but that doesn't mean the tool isn't useful. The tool has to be useful for the cases where you need additional information beyond what you have in your point of service system. So don't expect, if you're building a secondary system, everybody's going to go in there 100 times a day. Some people will go in there 100 times a day, but some people will go there once every 2 weeks because that's the point in time in their clinical workflow where they need that additional information beyond which they have in their own system. And if you want people to adopt a secondary system beyond their point of service, you better have a pretty compelling value proposition for them. There's this concept that I really love called normalized deviance, which, really I think was alluded to by a couple speakers, which is, you get so used to things being screwed up that you just accept that as being normal and you carry on. And so if you build a secondary system and there's any impediments to access with respect to workflow, login procedures, speed, performance, etc., people will very quickly sort of say, you know what, I'll just revert back to my normal process, which is I operate without all the information, and that's that. And that's a shame, and that's a lost opportunity. So really need to make sure that that value proposition is compelling when you open it up. And the other thing is, you have to realize that there may be competing priorities to yours or competing systems that are already out there. And clinicians in particular are very loath to leave existing systems that they know, even if those systems have warts and don't work very well. They're very loath to jump to another one unless the new one is really, really, really firing on all cylinders for them. I think the other thing, another thing I want to talk about is the funder and the clinicians need to be able to talk freely. That doesn't always happen. They are sometimes very farly separated in terms of where their domains of influence are and where they interact with each other. And when they do have an opportunity to talk fairly freely and realistically, then you can avoid some of the challenges. You can avoid a common thing that I think we're all guilty of here, where we overestimate benefits. Because we make naive assumptions about, okay, well, we'll give it to how many, 100,000, 300,000 users, and every one of them will accrue a certain amount of benefit. Not likely the case. The other thing is we sometimes double count benefits because our project is going to deliver this, but another project's delivering that, and each one of us are counting benefits. So we have to be careful to put the right people in the room having frank conversations. And the other reason you have to put the funder and the clinicians in the room is because as you expand these systems, which are very costly, at least from an outflow point of view, not to say that there isn't benefit, but they are costly and you have to operate them. You need to make sure that the release plans for how you expand this thing actually meet clinical goals as well as funder goals, because sometimes they're aligned and sometimes they're not, and there needs to be some kind of negotiation around that. And I think that's equally true as we appropriately bring the patients into the solution. We need to hear their priorities, not just the funders and the physician priorities and the other allied professionals' priorities. Okay, so here's another learning. I've been in e-health for a long time, or digital health, and we used to always say it's not about the technology, it's about the people and the processes. Well, I'll tell you one thing, it is about the technology. When the technology fails, the clinicians will walk, and the patients will for sure. So technical execution has to be flawless. You have to have test beds that are exactly the same as production environment, and you have to have test data in production environments. I'm putting that out there, all you privacy folks out there. I've got lots of things to say that you may not like, but you need to have real test data in production environments. It's not good enough to just look at it in test environments. You need real test data in real environments so that you can actually see what you're about to release into the space. Performance matters as much as functionality, and content probably matters more than both. So we've got lots of examples of things that are not very pretty, certain hospital information systems names that I won't provide, and they have huge adoption because they perform and they have the content that people want. So make sure that you get that balance right between performance, functions, and content. And clinicians, like clinicians, we assume that you've built all these systems to be clinician grade, was what Peter and I would often refer to. Clinical grade means you can't have prolonged downtimes. It means you can't take an 18-hour process to upgrade your system. That's not acceptable for us because there's a super high likelihood that during those 18 hours we need that system. And we need to be able to see all the releases in pre-production environments that are realistic. So this one's about vendors and issuers of RFPs. So issuers of RFPs need to be honest about what's doable in the timelines, not what's politically required to get done in timelines. I think that's really important. And the vendors, you see, you guys are not incented to tell the issuers that their expectations are unreasonable. But I think you ought to. I think responsible vendors should say, I love this RFP, I think it's going to bring great value, but what you're asking for on that timeline might be politically valid, but it's not valid in terms of ability to deliver. Almost done. Okay, so back to so privacy and security. My experience with sharing of health information, which I've had a fair bit, not only in connecting GTA, but in terms of working with liberating data from our lab information system to electronic medical records, and building our own proprietary interface to connect our family health team to our hospital before provincial grade solutions existed, is that issues related to privacy and security will take as much time and resource as issues related to technology and adoption. And I don't think it has to be that way, but that is the environment that we're working in. So you better build that into your project plans. One of the shocking things for the clinicians in Connecting Ontario was, although we have a privacy framework that supports the circle of care, which is a really good thing, we don't have privacy frameworks that support the informatics role very well. So, you know, the informatics role is often a clinician who helps to troubleshoot and to test systems, and it is an absolute mandatory requirement for a safe system. And unless you can get lawyers who will give you a very liberal interpretation of assisting to provide care, in a shared environment, it can be very difficult to get informatics access to do the testing and to do the troubleshooting that's required. And in order to do the testing and the troubleshooting that's required, they will need to look at PHI. That is a fact of running a safe system, and we need to actually have advocacy from groups like Infoway and Chief and Coach to make sure that we make that as simple as possible. It took Cindy sticking out her neck for us to make sure that informatics folks could, well, that's what it took, right? It took leadership, and so I'm calling out this group to say we need some leadership to make sure that in addition to having a private and secure system, we have a safe system. And to have a safe system, we need to be able to test and troubleshoot in production environments to make sure that they work properly. I guess the last thing that I would say on the privacy and security front is the only way that we're going to actually reduce the time and resource that's required in order to have a private and secure system is to change the mantra, I believe. And I think this connects well back to the previous discussion about patient engagement. I think we have to actually put the power of privacy and security back in the patient's hand, because we're trying very hard to do this in a sort of this old-fashioned concept of our fiduciary duty to keep that piece of paper safe in our closet. But this is a different environment, and I think the way that we're going to make progress and to make the system shareable is to put the patient in charge, because the lawyers don't want sharing. Every single time I've been in a shared health program that was about to launch, there was a last-minute delay because the lawyers weren't comfortable. You know, my favorite story about that is I was involved in the early testing of, as I mentioned, connecting OLIS, our Ontario Lab Information System, to EMRs, and I was going to be the first clinician, and we had made an agreement, one clinician, and only your own patients, and we've done all the right things. And the last minute we had to stop because an organization, and one of the people in this panel is in that organization, said, well, yeah, we've been contributing to that for 5 years, but we didn't expect anybody to look at it. So the lawyers want us not to share as they protect their clients' interests, but the patients need us to share. And the clinicians need that information in order to support the co-partnership model that we're talking about. So we need to advocate for bringing some sense back into that place. Thanks.
So wise words from David, Sun Tzu, Daien. So thank you. I think you're up to 1,000 battles, David. And Asim, would you like to come on up? And Asim will give us a little bit of a frontline clinical perspective and maybe some other thoughts as well. So
yeah, I mean, Dave took like 8 of my 10 points, so I don't even know what to talk about. I questioned my sock selection. I didn't know there was going to be chairs up there, so. Yeah. Yeah, so it says Canada Health Infoway there, but I'm relatively new there, so I'm just getting my feet underneath me there. But I was going to play my clinical hat that I wore as part of this journey, and it was an incredible journey for me personally, and it kind of pulled me into this provincial stream essentially. I was happily working as a simple, humble emerge doc in my little world of very little information when patients come in. So I get little snippets of this and snippets of that. Maybe I have a health record in my HIS system. Maybe I have a diagnostic imaging report. Maybe I have a consultation note. And that's basically all I've got. And I'll give you an example. I was working Sunday night. I do nights now because I have 2 day jobs. So I work evenings and nights. So I was working Sunday night. It was 1 o'clock in the morning, and a patient rolls in, EMS, young woman, lower abdominal pain, and she says just a couple of words. She's having so much pain. She says, Mount Sinai, drainage tube taken out. Right, so that's all I kind of had. I went right to Connecting Ontario. Took a little while for us to get it fired up, but it got fired up, and we'll talk about that in a second. It got fired up, and lo and behold, I've got these amazing records, tubal ovarian abscess, all kinds of antibiotics she was on, cultured, a number of different specialists that had these awesome reports that I could work with. So, I mean, I don't know what I would have done, frankly. I can't even turn my mind back 5 or 10 years ago what I would have done in that scenario. So treatment and previous antibiotics she was on and what she was sensitive to as well was all there right in front of me. So it proves its value for me daily. And the challenge really is around making sure that it, knowing when to use it. So as an emerg doc, I don't always know when to use it. She had to say Mount Sinai to help me trigger the use of it. And if I had to build this again perfectly, I'd love for my HIS to kind of shout out at me and say, by the way, there's data sitting in this portal and you may want to look at it. That would be an ideal workflow piece. But anyway, so a few triggers helped me go into the system and get it. For us, I think I bought into the federated model very early. I think having Dave and Peter lead it, they knew that clinical adoption was around workflow. So very, very early, we said, let the organizations that are already responsible for credentialing clinicians and providers help pass that data along. If I had to log into something else or wait, that would take an inordinate amount of time, and I probably wouldn't do it in a busy shift. But that was a winning formula. The other winning formula was integrated into EMRs. So I'm all about workflow. I know technology is critical, but if the workflow isn't working, you can have the best system in the world, and it's going to collect dust. So the integration into the EMR and our HIS was absolutely pivotal, and passing along patient information was absolutely critical. So provider and patient information passed along was a critical success factor. And I think having clinicians involved early in that process really helped. So the engineering and the whiteboarding and the designing of this whole project fit and hit all the right spots. The next challenges are really around clinical adoption. And I think for me is like, I don't want to have tutorial sessions where physicians and clinicians come and spend an hour and have stale croissants and try to learn about a system. I think, or even a YouTube video, like people are very, very busy, and I think systems need to be intuitive, right? They have to be simple and intuitive. I didn't have to show my kid how to use an iPhone or an iPod. It has to work almost out of the box, and that's the functionality we expect. I download an app, and within minutes I'm figuring most of it out. So that's what we need to build into our systems as well. We try to do sessions, we try to do all kinds of stuff. We had lunch and learns. It didn't work, nobody came. So we did departmental meetings. So we went to departments and demoed the product, and I think that helped. People had to see it. But the biggest thing is that it worked. The biggest thing that it worked, and all I had to do is tell people, well, it's got this kind of data, and they're going to go, oh, that's cool. It includes these hospitals where your patients go. That's cool. And then they're looking over the shoulder of another clinician that's using it, saying, what are you doing over there? And they say, well, it's got all this data, and I can print it, I can include it in the chart. It's brilliant. So word of mouth really, I think, in the end, accelerated the project. So they asked me how many people I want to enroll. I said, well, I guess I'll enroll everybody when they're initially asking me, because I didn't know who was going to use it and when. And I was surprised by some of the users. Our preoperative clinics, our nurse practitioners are huge users of it. So people that I wouldn't expected use it more than I thought. But really the word of mouth is what spread, and that's how people used it more and more. So I think, I think the ease of how we set it up with the portlets, the ease of access made it a winner. The next problem you run into is the amount of data that's in there. So that if I wanted to find the last, echo report or an maybe a nephrology consult, we now have to architect it and think about how do we get that data quickly. I don't want to scroll down and down and down and find that nephrology report. So we need to now, once we get all this data in there, is how do we architect it in a way that we can access the data quickly and get to where we want to go. And I think we need maybe some help with that. And part of it is the way we get the data into the HIAL to begin with. The data is what it is, and we work quite hard to standardize that, but there's probably further work to do. So those are the things that I guess I'm challenged with. And the other thing we don't control very well is the hospital aspect of who owns this system. So at our place, we don't have the right browser, we don't have the right, we got all these issues. So my hospital owns half or maybe more of the time it takes to launch the system, right? So I think even in a federated model, we have to work with all our partners to make sure that the access points and standards are up to snuff, that everybody's having the same experience. If I go to a WOW, I get one experience in our place. If I go to a plugged-in system, I get another experience, and that's totally our fault in terms of managing it. So the IT infrastructure that you have to put in place to make these things successful and have a standardized user experience are critical as well from our standpoint. So those are the main things that I learned. I was a clinical champion, and I have to pass that torch on now to other clinicians in the organization as we grow. So that's kind of the main points that I had, but mainly around the trenches and mainly the power of the tool once it's put in place. Thanks.
Thank you very much, Asim. So one of the design features that we're still waiting for is the search button at the top of the portal. So anyway, it'll get there, but that's what you were describing in a sense. Some very key sort of practical points, so thank you. So I'd like to hand over to Sarah, and Sarah will give us some comments now looking from the slightly different perspective of Connecting Ontario, and then we'd be very pleased to open it up for the audience here. So thank you, Sarah.
You might have noticed Peter leaned over and he said, you can do that 8 minutes and 3, right? So we leave time for... So all that really means for those of you that know me is I'm just going to talk really fast because I refuse not to make the points. So thank you. It's really a great opportunity to be talking about the view from the community and the importance of the work that we've done and the investment in the province has made in the community and really focused on physicians. And I appreciate there are lots of health professionals that are incredibly important as part of care delivery, but my mandate is physicians, and I just want to make my comments in that context. So we currently have a very connected physician community, but over 13,000 physicians in the province who are using electronic medical records. And we spend a lot of time actually, which I think is a bit distracting, trying to differentiate between EMRs and EHRs. And I actually really like the new digital health strategy rubric because I think we all understand the importance of a connected agenda. And in fact, I want to move away from Connecting Ontario to Connected Ontario and think that a really important piece of this message is, in order to really deliver on the promise, it's about integrating information at the point of care. And it's less about repositories and it's less about this sits here and this sits over here. But for the clinicians that, work every day in treating patients, when they open up their EMR, which is their point of service tool, they really want to experience all of the information about their patient at the point that they're delivering care to their patient. And I think that relentless focus on integration and compiling those provincial assets is really important. And I think that conversation is really importantly changing as we have matured. And maybe it's a stroke of genius or a stroke of convenience, I'm not really sure, but I think that, as others have said, it's been a really interesting journey in the province. We set about a series of the sectors all working concurrently in developing strategy, right, and delivering. So whether that was public health, whether that was in primary care, whether that was the acute sector, whether it was the connecting, whether it was repositories. And in fact, it's been really interesting that we've all progressed concurrently. And we're at a state of maturity now that I think is quite interesting, that we have all of these concurrent assets at a state of being able to liberate that data or move that data around? And how is it we effectively work with our vendors, those assets, these opportunities to make that data available? And we do that in different ways, and we certainly do it from our control piece in terms of working with vendors around a specification and certification program. We work with physicians around change management and so on. I want to build on a couple of comments that have been made about the importance of physician engagement and how we do that the most effectively. And it's been my experience that physicians don't have a lot of risk tolerance, and this, I think David and others have alluded to, and capacity for downtime or getting it wrong, right? Like their job is delivering healthcare, and our job ought to be delivering technology that makes delivering healthcare easier for the physicians and the patients that they serve. And I think the change management, the integration, the experience, the clinical workflow are incredibly critical, whether that's Connecting Ontario's view or the community view, right? It has to be intuitive, it has to be easy, and it has to be integrated, and that's incredibly important. And I'm not looking at my notes, and I have pages of them, and I don't seem to be making those points. So. We know that certainly about 80% of the data around the patient actually resides in the community-based EMR. That's a very rich data source. We're incredibly challenged at the moment to move data out of EMR. So we're getting a whole lot better at consuming data in the EMRs from various other delivery partners, and Connecting Ontario certainly one of those. But we now need to think about how we move data out of EMRs and really support that information flow in the continuum. Reference was made earlier about receiving reports, hospital discharge summaries, and information. Really happy to say we have vendor partners in the room that we've been really successful with the support of Ehealth Ontario around delivering a hospital report manager solution that meets about almost 7,000 physicians, where discharge information is directly integrated into the EMR, seamless there. Within half an hour of that discharge report being available, it's available to the physician in their EMR at the point of care. Incredibly important. Working on e-notifications, so physicians actually get admission and discharge messages immediately when a patient is admitted into an emergency department or admitted into the hospital. Incredibly important to support physicians at the point in which, in the primary care home, and to give them the information tools that they very much need. So, I think, I guess my real theme in this is really not about any single asset. It's not Big Bang. It really, really, for me, is an integration discussion on the importance of us actually building now and taking along those concurrent, really good strategies where everyone's kind of worked fairly independently, but effectively. And now thinking about how, as partners and as we sit, together at the front of the room, how it is we actually do that around the patient journey, the patient experience, around providing information. Our healthcare providers, we need to create some capacity for them to change. So, it's not good enough just to have technology and bright, shiny technology. We actually need to make space to help our physicians and clinicians create safe space around change management and to support them along that journey. That's an incredibly important and sustained investment. And it's a really good shout out to Canada Health Infoway, because they have funded and supported a peer leader program. And we know, working with physicians, I know this is going to be a shocking surprise to you all, learn best from other physicians, and clinical leadership is incredibly important in terms of moving that around. So we need to reduce the noise. We need to, as a system and as a group of folks that are here in this concurrent space, really decide on the priorities that we want to drive forward and be relentlessly focused on those priorities around integration so that we can really kind of deliver that big bang. So access to information, I think, is no longer sufficient. Integration is absolutely necessary. And my pre-lunch analogy is, I think we're really about ready to present the perfect sandwich, right? We have this array of digital health tools and technology. We have healthcare providers, and we have the healthcare consumer. And those three elements together, those three ingredients, I really think are motivated and really positioning us for the future.